Good morning, Assalamu alaikum. So I've been given this talk, so I thought I'd be as comprehensive and as objective as possible. So every talk starts with a definition, so I thought I'd define the parameters that I've been given. So this is the original Calgren and Lawrence categorization, and we're talking about pictures C and D. So is there a pointer anywhere? And then if you want to go on the outer bridge classification, again, what we're looking at are pictures D, E, and F. So just to set the scene. Which one? Okay. No, I just want to point to it. There's a pointer. Thank you. So again, just to clarify, this is the type of pathology that I'm talking about. So I'm not talking about anything less than that. My daughter spent some time coloring in this slide. So this is orthobiologics as summarized. So we could get it from blood products, there's cell-based therapies, and there's other stuff. So then within the autologous blood products, you've got the PRP. PRP, there's not one ubiquitous PRP. The composition differs. So you can get the PRP, which is good for tendons, and PRP that's good for potentially inflammation. And what we could do, we could talk about the different types maybe over coffee, but I thought in 10 minutes I can't go through all the differences. But then there's all these things like autologous anti-inflammatories, autologous conditioned serum, autologous protein solutions. And I know some of these companies have sponsored this meeting. So just to be aware that these do come under these blood products. Then there's cell-based theories, BMAC, etc. And then within this, there's a difference between stromal fractionation versus MFAT, which is microscopic fat. And different companies almost confuse and mix this fraction. And then there's cultured cells. This is something that you have to send to a lab. So it's not something you're going to get in your clinic. And again, they are misnamed. So someone could be giving you something at point of delivery and it'd be autologous blood product, but call it something that you should only expect in a cultured product. And there's different placenta-derived miscellaneous products. So let's get into some of the evidence so that we can answer the questions. This is a nice review, and this shows what are the current available biologics and its clinical applications and the type of cells in each one. So if you look at PRP, sorry, this pointer doesn't project onto the screen. It's not just one thing. It's a whole group of things that you are injecting. And that's where the heterogeneity comes to. And that's where it's difficult to perhaps do trials to see what's working, what's not working. And we can go through, again, because of shortage of time, I'll gloss through it. So now I'm trying to answer, is it a fact? So this is an 11-year review of the orthopedic literature. It's kept me up many nights because it's actually a very interesting read. Both these papers are. And there's another one, is the current status of all the clinical trials of biologics. And as you can see, the number of publications is increasing. So you go from 2009, relatively steady, and then look what's happening in 2018. And what's encouraging maybe is the level of evidence, which is the one on the right at the top. They are level 1 evidence papers. These are in progress. Okay, so you could say that people are trying to find an answer. And then the journals that are particularly interested in this subject, and they're all high impact factor journals. So we can't say that research isn't being done. It is being done. Now, if you look at a summary of all the clinical studies evaluating treatment of various musculoskeletal order parts, you can see that the knee is predominantly the one being studied. But also maybe it's the one that's easiest to deliver something to by the greatest number of people and the greatest disciplines of people. And you don't have to have particular qualifications to deliver them. So it is quite an attractive area to study, and most studies are funded by companies nowadays. That's the state of a poorly funded healthcare system, say in the UK as well. NIHR funding is highly competed for. A lot of studies are company-based, and so it's no surprise that knee is a particular hot point. And then study type and orthobiologic. PRP, as you'd expect, is the one that's greatest being studied. So coming into, again, if you look, this is again a graphic showing that the knees are most studied, and then MSCs have the most number of trials along with PRPs. And here's another one going from 2019 to 2021. You could see after a sudden rise, it is beginning to plateau somewhat. And this is where currently, these are the phases in which each of these trials are. So you could see a lot of them are still incomplete. Almost a third of them are incomplete. But what surprised me, 16% we don't know which phase the trial's at. And these are meant to be quite regulated trials. Complete 40%. So we'll move on just a bit. And again, these are the number of clinical trials on MSCs and PRPs for the treatment of cartilage defects and osteoarthrosis. You could see a huge amount of different orthobiologics that are being studied. You could see, though, that the most number of trials are the top two. And again, the comments I've made earlier apply. Now, this is brief outcomes. So if you look at the outcomes as you're going, I'll let you just, I'll leave this slide up for 20, 30 seconds. You can see that there are some positive things to say. But the positive things are subjective scores of pain, not alteration of the disease. So there's no MRI-based study showing that the cartilage has now recovered, but the patient feels better. So if we are in the business of making the patient feel better, maybe this is something just to consider. And it goes on. And then I narrowed this down to PRP, which is what we probably are most mindful of and want to know about. And there are some of these studies I've selected out reviews of PRP. And here's one, the temporal effect of PRP, pain and physical function. So I've narrowed it down to these things. And you can see here, here's how the scoring is. There are very few papers on 3, which I was tasked with, and almost none for grade 4. So this then leads me to the risk of bias. So everything read is read for a reason, and here comes subjective bias and observer bias. So if I've paid for something, or if I know that I've had a drug, then that naturally biases a patient. So when you do trials, and I'm currently engaged in one with drugs within knee replacements, then it's the best way is a double-blind trial where the patient doesn't know what they've got, and the reviewer doesn't know what they've had. There are very, very few trials of that. So to put everything together, these are the organizations that give recommendations, and this is what they're recommending. Now, ESCA, the European Society, are supporting it, but perhaps that's also because that's the most recent review back in 22. So we can see where the trials are, we can see where the trials are escalating. So I think it's not surprising that maybe there is more recommendation in 22, whereas there was a downgrade from the AAOS on 21. So I've approached this with an open mind because my views, I think, are what made me be asked to do this lecture in the first place and how I've commented before. So it's with a completely open mind. And then the last couple of slides, the utilization by sports medicine physicians. If you see, this is the total users and where they've combined, the orange is where they've combined it with hyaluronic acid. So you don't really know which one is working over there. So the next is, so why, the question was, why are you injecting it? So while the bar on the left is that the user believes that actually what they're injecting is good. The small bar on the right is because someone else is injecting it. Their competitors are injecting it. That's why they're injecting it. So although a lot believe in what they're doing, but not an insignificant amount are doing it because everyone else is doing it. So in summary, there is no evidence supporting the use of orthobiologics in grade 3/4. And for next year, maybe I can talk about the non-orthobiologics. I won't go over time. And this, again, is the current status of non-orthobiologics. Thank you very much for your time.